This lecture will go over hypothyroidism. We've already talked about hyperthyroidism, which is a condition where there's increased thyroid hormones and also resulting in increased metabolism in the body. Now we're talking about hypothyroidism. Hypothyroidism is a result of low levels of thyroid hormones that result in decreased metabolism in the body. Thyroid cells may fail to produce sufficient levels of thyroid hormones for several reasons. Some of the cells themselves are damaged and no longer function normally. At other times, the thyroid cells are functional, but the adult does not ingest enough substances needed to make the thyroid hormones, especially iodide and tyrosine. When the production of thyroid hormones is too low or absent, the blood level of thyroid hormone is also low, and the patient has decreased metabolic rate. This lower metabolism causes the hypothalamus and anterior pituitary gland to make stimulatory hormones, especially thyroid stimulating hormone TSH, in an attempt to trigger hormone release from the poorly responsive thyroid gland. The TSH binds to the thyroid cells and causes the thyroid gland to enlarge, forming a goiter, although thyroid hormone production does not increase. Most tissues and organs are affected by the low metabolic rate caused by hypothyroidism. Cellular energy is decreased, and metabolites that are compounds of proteins and sugars build up inside the cells. These protein and sugar compounds increase the mucus and water and form cellular edema and changes in organ texture. The edema is full of mucus and water and is called myxedema. Myxedema isn't like other edema that is caused by water alone. This edema changes the patient's appearance. Non-pitting edema forms everywhere, especially around the eyes and the hands and feet and between the shoulder blades. The tongue thickens and edema forms in the larynx, making the voice husky. General physiologic function is decreased. Myxedema coma is sometimes referred to as a hypothyroid crisis. It is a rare and serious complication of untreated or poorly treated hypothyroidism. The decreased metabolism causes the heart muscle to become flabby and the chamber size to increase, which results in decreased cardiac output, decreased perfusion, and gas exchange in the brain and other vital organs, which makes an already slow cellular metabolism worse, resulting in tissue and organ failure. The mortality rate for myxedema coma is extremely high, and this condition is a life-threatening emergency. Most cases of hypothyroidism in the United States occur as a result of thyroid surgery and radioactive iodine treatment for hyperthyroidism. Please review Chart 63-6 that lists the key features for hyperthyroidism, as I will not present them during the lecture. In addition to studying Chart 63-6 key features, please also read over under Assessment, History, Physical Assessment, Signs and Symptoms, and Psychosocial Assessment on your own. In regards to lab assessment, laboratory findings for hypothyroidism are the opposite as those found for hyperthyroidism. T3 and T4 levels are decreased. TSH levels are high in primary hypothyroidism, but can be decreased or near normal in patients with secondary hypothyroidism. The priority problems for patients with hypothyroidism include decreased gas exchange and oxygenation, hypotension and reduced perfusion, reduced cognition, and the potential for complications from myxedema coma. Now we'll move on to planning and implementation. Respiratory and cardiac problems are serious, and their management is a priority. The most common cause of death among patients with myxedema coma is respiratory failure. We want to make sure that our patient has adequate gas exchange. We want to monitor rate and depth of respiration and the adequacy of gas exchange. Measure O2 saturation with pulse ox and apply oxygen if needed. Auscultate the lungs for a decrease in breath sounds or presence of crackles. The patient who is receiving sedation may not have adequate gas exchange, so we need to pay particularly close attention to that patient. In terms of hypotension, the patient may have decreased blood pressure, bradycardia, and dysrhythmias. Nursing priorities are monitoring for condition changes and preventing complications. Monitor BP and heart rate and rhythm and observe for indications of shock, such as hypotension, decreased urine output, and changes in mental status. If hypothyroidism is chronic, the patient may have cardiovascular disease. Instruct the patient to report episodes of chest pain or chest discomfort immediately. The patient requires lifelong thyroid hormone replacement. Synthetic hormone preparations are usually prescribed. The most common is levothyroxine sodium. Therapy is started with low doses and gradually increased over a period of weeks. The patient with more severe symptoms of hypothyroidism is started on the lowest level of thyroid hormone replacement. This precaution is especially important when the patient has known cardiac problems. Starting at too high of dose or increasing the dose too rapidly can cause severe hypertension, heart failure, and myocardial infarction. With myxedema coma, the drug may need to be given IV because of the severely reduced motility and absorption of the GI tract. Teach patients and families who are beginning thyroid replacement therapy to take the drug exactly as prescribed. Assess the patient for chest pain and dyspnea during initiation of therapy. The final dosage is determined by blood levels of TSH and the patient's physical responses. Monitor for and teach the patient and family about the symptoms of hyperthyroidism, which can occur with replacement therapy. In terms of cognition, observe for and record the presence of and severity of lethargy, drowsiness, memory deficit, poor attention span, and difficulty communicating. These problems should decrease with thyroid hormone treatment, and mental awareness usually returns to the patient's normal level within 2 weeks. Orient the patient to person, place, and time, and explain all procedures slowly and carefully. Provide a safe environment. Family members may have difficulty coping with the patient's behavior. Encourage them to accept mood changes and mental slowness as symptoms of the disease. Factors leading to myxedema coma include acute illness, surgery, chemotherapy, discontinuing thyroid replacement therapy, and the use of sedatives or opioids. Problems that often occur with this condition include coma, respiratory failure, hypotension, hyponatremia, hypothermia, and hypoglycemia. Myxedema coma can lead to shock, organ damage, and death. Assess the patient with hypothyroidism at least every 8 hours for changes that indicate increasing severity, especially changes in mental status, and report these promptly to the healthcare provider. Treatment is instituted quickly according to the patient's symptoms and without waiting for lab confirmation. Again, please review Chart 63.7 that lists the best practices for emergency care of the patient with myxedema coma. Please review the care coordination and transition management section for hypothyroidism on your own, and review any of the boxes that also are present in the next couple pages.